Welcome to Surgery Smart, Cut to the Core podcast, where we break down essential surgical topics to help you understand surgical conditions. I'm your host, Major Munish Chauhan, and I'm a General Surgery Registrar in the British Army and at Oxford Dean. I'm also a Senior Research Fellow at the Centre for Army Leadership, with an interest in self-leadership, resilience, and metacognition. Feel free to connect with me on LinkedIn if you have any questions or interest in these topics. In today's episode, we'll start by looking into the anatomy and physiology of the esophagus, providing a solid foundation for understanding its function and diseases that affect it. The esophagus is much more than just a food pipe. Its intricate structure, coordinated physiology, are vital for swallowing, preventing reflux, and maintaining homeostasis. By the end of this episode, you will have a clear understanding of its layers, sphincters, blood supply, lymphatic drainage, and the essential role that the vagus nerve plays in it. So let's start with the functional anatomy of the esophagus. The esophageal wall, although it may seem like a simple conduit for food and liquids, it's actually a finely tuned structure with 4 distinct layers, each playing a crucial role in its function. The first layer is called the mucosa, the innermost layer of the esophageal wall. Picture this as a protective lining made of non-keratinized squamous epithelium. Its primary function is to prevent the wear and tear caused by the passage of food. This layer is remarkably durable, but it's not invincible. As we approach the gastroesophageal junction, where the esophagus meets the stomach, the epithelium transitions into columnar epithelium, which is more suited to the acidic environment of the stomach. However, this area is also a site of vulnerability. Chronic exposure to stomach acids, such as in gastroesophageal reflux disease, can lead to a condition called Barrett's esophagus, where the lining undergoes abnormal changes, significantly increasing the risk of esophageal cancer. Beneath the mucosa lies the submucosa, a layer which is rich in glands that secrete mucus. This mucus acts as a lubricant, making the passage of food smoother, while also providing a protective barrier against the stomach acids. If this layer thickens abnormally, as seen in conditions like achalasia, it can disrupt the esophagus's ability to propel food effectively, leading to significant symptoms such as difficulty in swallowing. Next, we come to muscularis propria, the workhorse layer of the esophagus. This layer is where the real movement happens. In the upper third of the esophagus, the muscles are striated, giving us voluntary control over the initial stage of the swallowing. As we move further down, the middle third contains a mix of striated and smooth muscles, transitioning into the lower third, which is entirely smooth muscles. This smooth muscle is controlled involuntarily, ensuring that food continues its journey to the stomach without us even having to think about it. Disorders involving this layer can lead to significant problems. For example, esophageal spasm can cause intense chest pain, often mimicking a heart attack, while conditions like nutcracker's esophagus results in painful and forceful peristalsis. The outermost layer is called the adventitia, a loose connective tissue that anchors the esophagus to the surrounding structure in the neck and in the mediastinum. While it may seem less glamorous compared to the other layers, the adventitia is vital for keeping the esophagus stable, as it works to transport food and liquids. Now let's talk about the sphincters, the guardians at each end of the esophagus. These are not just simple closures, they are critical pressure zones that keep everything in balance. At the top, we have the upper esophageal sphincter, made primarily of cricopharyngeus muscle. This sphincter prevents air from entering the esophagus during breathing, an essential function for smooth swallowing and respiratory health. When this sphincter malfunctions, conditions like Zenker's diverticulum can occur, where a pouch forms in the esophagus, leading to regurgitation and bad breath. At the bottom lies the lower esophageal sphincter, a key player in preventing the gastric acid from flowing back into the esophagus. Interestingly, the lower esophageal sphincter is not a distinct anatomical structure, but it's rather a physiological zone of high pressure. When it functions properly, it keeps the stomach content where they belong in the stomach. However, if the lower esophageal sphincter weakens, it's a major cause of gastroesophageal reflux disease, leading to heartburn, inflammation, and long-term complications of it. The esophagus, although it's just a muscular tube, but the understanding of its functional anatomy is crucial for surgeons. Each layer and sphincters work in concert to ensure that swallowing is smooth, efficient, and safe. Understanding these intricacies is essential not only for recognizing normal function, but also for diagnosing and managing a number of esophageal disorders. Now let's talk about the physiology of swallowing and esophageal motility. Swallowing, something we often take for granted, is one of the most intricate processes in human body. It's a finely choreographed sequence involving voluntary and involuntary actions, ensuring food and liquids make their way safely from the mouth to the stomach. Let's break it down in 3 phases. The first phase, the oral phase, is entirely under voluntary control. Imagine taking a bite of food and beginning to chew. Here, the tongue plays a starring role, skillfully pushing the food bolus towards the back of the mouth. This step may seem simple, but it's very critical. If the tongue loses its function, such as in cases of paralysis due to neurological conditions, this phase becomes compromised. Patient may struggle to move the food properly, leading to difficulties in swallowing and increases the risk of choking. Once the bolus reaches the back of the throat, the second phase, the pharyngeal phase, begins. This phase is reflexive, meaning it happens automatically, without conscious effort. As the bolus moves into the pharynx, the soft palate elevates to close the nasopharynx, preventing food from entering the nasal cavity. At the same time, the larynx also elevates and the epiglottis folds down to seal off the airway, protecting the lungs from aspiration. This is a marvel of reflexes working in perfect harmony. However, in individuals recovering from stroke, these reflexes can often become impaired. Without proper closure, the food and liquids may enter the lungs, leading to complications such as aspiration pneumonia. Finally, we enter the esophageal phase, where the food bolus makes its way down the esophagus. This phase is powered by peristaltic waves, rhythmic, coordinated muscle contractions that propels the food downwards. When the bolus reaches the end of the esophagus, the lower esophageal sphincter relaxes to allow the passage of the food into the stomach. Once the bolus has gone through, the lower esophageal sphincter tightens again to prevent stomach acid from flowing back up into the esophagus. But what happens if the process does not go smoothly? That brings us to the concept of esophageal motility. There are two types of peristalsis in the esophagus. The first is primary peristalsis, which is initiated by the act of swallowing. It's a coordinated wave that begins at the top of the esophagus and continues downwards. The second type, secondary peristalsis, is more of a backup mechanism. If there is any residual food left behind, or if gastric content reflux into the esophagus, the secondary peristalsis kicks in to clear it out. When these processes are disrupted, as in conditions like achalasia, the consequences can be profound. Achalasia involves the loss of coordination between peristalsis and the relaxation of the lower esophageal sphincter. As a result, food gets stuck in the esophagus, causing dysphagia, difficulty swallowing, and even regurgitation of the undigested food. These symptoms can significantly affect the patient's quality of life and require targeted medication and surgical interventions. So while swallowing may seem automatic, it's a beautiful interaction of anatomy and physiology, with each phase building upon the last. From the voluntary control of the tongue to the reflexive closure of the airway and the powerful waves of peristalsis, it's a process that demands respect for its complexity, but also sheds light on challenges faced by those with swallowing difficulties. In the next part, let's talk about the esophageal blood supply and the lymphatic drainage. The esophagus is not just a simple muscular tube, it's a well-connected structure with complex blood supply and lymphatic drainage. Understanding its blood supply and lymphatic drainage is a key to recognizing the clinical challenges associated with esophageal disease, especially cancer and conditions like esophageal varices. Let's start with arterial supply. The esophagus is divided into three distinct regions: the cervical, thoracic, and abdominal, and each has its own arterial blood supply. The cervical esophagus is supplied by the inferior thyroid artery, a branch of the thyrocervical trunk. This artery ensures the upper esophagus gets its steady blood flow. The thoracic esophagus, which runs through the chest, receives its blood supply from the branches of the thoracic aorta. These branches play a crucial role in maintaining the blood supply along the midsection of the esophagus. Finally, the abdominal esophagus, the part just above the stomach, is supplied by the left gastric artery, a branch of the celiac trunk, and the left inferior phrenic artery. These arteries not only nourish this region but also form vital connection with the stomach's blood supply. Now let's talk about the venous drainage. The esophagus has a dual drainage system that connects both to the systemic circulation as well as to the portal circulation, making it a critical site for venous anastomosis. In the cervical region, venous blood drains into the brachiocephalic veins, which are part of the systemic circulation. The thoracic region drains into the azygous and hemiazygous veins, which are also the systemic veins. They empty into the superior vena cava. The abdominal esophagus drains into the portal system via the left gastric vein. This dual drainage is clinically significant. In conditions like portal hypertension, where the pressure in the portal system increases, blood flow is redirected into the systemic veins through the esophageal anastomosis. This leads to formation of esophageal varices, which is dilated veins in the lower esophagus. Varices can be a ticking time bomb. They are prone to rupture, causing massive upper GI bleeding, which is often life-threatening. Managing this requires a combination of endoscopic, pharmacological, and sometimes surgical intervention. Now let's move on to the lymphatic drainage. The esophagus has a rich network of lymphatics, which is why cancers of the esophagus can spread very quickly. Like the arterial supply, lymphatic drainage also follows a segmental pattern. The cervical esophagus drains into the deep cervical lymph nodes. The thoracic esophagus drains into the mediastinal lymph nodes located in the chest. The abdominal esophagus drains into the celiac lymph node situated around the celiac artery. This extensive lymphatic system is a double-edged sword. While it helps the body fight off infections, it also provides an efficient route for the cancer cells to spread. That's why esophageal cancer often presents with advanced disease, as the cancer can easily metastasize to distant lymph nodes. Thorough lymph node staging is crucial for planning effective treatment, whether it involves surgery, chemotherapy, or radiotherapy. In summary, esophagus is more than just a food pipe. It's a dynamic structure deeply integrated into the body's vascular and lymphatic drainage. From its segmental arterial supply to its intricate venous and lymphatic drainage, each component plays a critical role in maintaining esophageal function and, when compromised, becomes a focal point for serious medical conditions, whether it's a life-threatening nature of esophageal varices or aggressive spread of esophageal cancer. These networks underline the importance of early detection. And prompt management. Now let's talk about the innervation of the esophagus. The esophagus receives dual autonomic innervation, meaning it's controlled by both parasympathetic and sympathetic nervous system, each contributing to its own function. Let's start with the parasympathetic system, which primarily involves the vagus nerve. The vagus nerve is the esophagus's powerhouse, driving key functions such as peristalsis, those rhythmic contractions that propel the food downwards, and maintaining the tone of the lower esophageal sphincter. The lower esophageal sphincter, although not a distinct anatomical structure, functions as a critical barrier to prevent gastric acid reflux. When the vagus nerve is damaged, as it can happen during surgeries involving chest and neck or from trauma, the consequences can be severe. Without proper parasympathetic control, the esophagus may lose its coordinated motility, leading to significant disorders like dysphagia or even complete motility disorders. Now let's talk about the sympathetic system, which plays a more modulatory role. Sympathetic nerves help regulate the blood flow to the esophagus and fine-tunes its motility, especially during stress. While they are not central to the day-to-day propulsion of food, their input ensures the esophagus can adapt to varying physiological demands. Understanding this balance between parasympathetic and sympathetic input gives us critical insight into physiology of the esophageal conditions. Let's touch on a few examples. Take achalasia, for instance, a disorder where lower esophageal sphincter fails to relax and peristalsis in the esophageal body is lost. This results from degeneration of mesenteric plexus, a critical nerve network in the esophageal wall. Patients experience significant dysphagia and regurgitation, making even simple meals a challenge. You can also consider gastroesophageal reflux disease, a condition where lower esophageal sphincter doesn't maintain adequate tone, allowing stomach acids to flow backward into the esophagus. This leads to irritation, inflammation, and, if chronic, mucosal damage. Over time, GORD can evolve into Barrett's esophagus, where the normal squamous epithelium is replaced by metaplastic columnar epithelium, a key risk factor for esophageal cancer. Speaking of cancer, understanding esophageal innervation, along with its vascular and lymphatic network, underscores why esophageal cancers often present late. Their ability to spread early via lymphatics makes accurate staging and prompt treatment essential. So let's talk about some of the key points to take away. Number 1, the esophagus relies on dual autonomic innervation, the parasympathetic vagus nerve for motility and lower esophageal tone, and the sympathetic system for modulating during stress. Number 2, disorders like achalasia and GORD highlight the critical role of vagus nerve and the lower esophageal sphincter in maintaining normal esophageal function. Number 3, chronic reflux can progress to Barrett's esophagus, increasing the risk of esophageal cancer. Number 4, a thorough understanding of esophageal innervation is essential for diagnosing and managing the complex conditions. Thank you for tuning into Surgery Smart Cut to the Core podcast. If you found this episode useful and valuable, please share it with your colleagues and get in touch with suggestions and future topics. Stay curious, keep learning, and as always, stay sharp. Until next time.